And the white bars represent whether the neurologist identified the patient as having problems with depression, anxiety, fatigue, or sleep. So you see the doctors did pretty good, did pretty well at identifying whether the patients had a sleep disturbance, with about 40% or so of the patients having sleep problems. Whereas depression, anxiety, and fatigue were present in about 40% of patients across the board, whereas less than 20% of the patients were recognized as having these problems by the neurologist. So only half the patients were recognized by their doctor, who knew them well and was following them as having depression, anxiety, or fatigue. So given the impact of these symptoms, it's important to think about what needs to be done to improve our recognition and treatment, and by just being aware that these occur is probably the first step. So to talk more specifically about depression, depressive disorders affect about 50% of Parkinson's patients. The range in the literature is from 20 to 90%, with the usual factors affecting whether or not what the prevalence rate is reported. For example, whether the patients were seen in a tertiary care setting, what diagnostic instruments were used, and other features of the sample itself. The clinical features of Parkinson's disease with depression can range from along the gamut of mild to severe depressive syndromes, with major depression being common, as well as minor depression also being common. There's some debate about whether the reports are overestimating the major depression rates, but at this point, I think what's most important is to remember that many patients will suffer from a depressive disorder that may be a more limited symptom, minor depression or dysthymia type syndrome, or it may also be a major depression. The important thing is to recognize that. You also see bipolar disorder as well as non-motor mood fluctuations, which I'll describe later. What's important is that the onset of depression does not appear to be related to the disease stage or the degree of disability in the patient. And as I'll show you with some additional data, a number of patients will develop depression even before the onset of motor signs, similar to the patient I described earlier before her Parkinson's disease was diagnosed, and the depression can occur late in the course of Parkinson's disease. So we see many patients with extreme disability who aren't depressed at all, and other patients who have barely any motor symptoms who are extremely depressed. What's important about depression is that it has a tremendous effect on quality of life, often more so than motor deficits themselves. It's also a major source of excess disability, economic strain, caregiver distress, and increased motor deficits, and also some data to support that. The majority of patients with Parkinson's disease will receive psychiatric care from their neurologist or from their primary care doctor, not from psychiatrists themselves or from a mental health specialist. In many cases, they're partially treated if they are recognized at all. I've mentioned before that a number of patients will have prodromal psychiatric pathology, and in particular, depression frequently precedes the onset of the diagnosis of Parkinson's disease, at least by 4 to 6 years. And there have been several studies showing this, with the relative risk of depression occurring before the onset of Parkinson's from 2 to 3. And even with the initial symptoms of Parkinson's disease, we'll see that a number of patients will have many symptoms that really overlap between depression and Parkinson's disease. So it can be difficult to recognize whether you're looking at symptoms of depression or whether you're looking at symptoms of Parkinson's disease itself. And this is data from very early on in studies of Parkinson's disease from 1967. They looked at the initial symptoms of Parkinson's disease. And what you see here is that about 10% of patients, at least, will have slowness or muscle cramps and aching, or depression and nervousness, fatigue, weakness, and facial masking. All symptoms that you could typically see in any patient, any geriatric patient, who might be presenting with a depressive disorder. So a recent study was looking at patients with early in the course of Parkinson's disease. This is the NET-PD study that's funded by the National Institute of Health. And these are a series of neuroprotective treatment trials. And what they looked at, what Dr. Ravina looked at in this analysis of the data separately, was what was the rates of depression occurring in these patients with early untreated Parkinson's disease. So the patients have been diagnosed with Parkinson's disease, but they weren't being treated symptomatically for the motor symptoms of their Parkinson's disease. And what they used to diagnose depression caseness, not really using an actual diagnostic exam, but they used the geriatric depression scale, the 15-item geriatric depression scale. And if the subject had a score of 5 or more on the geriatric depression scale, they were considered to have clinically significant depressive symptoms. And what they showed in this sample of patients with very early onset Parkinson's disease was that 28% over the 15 months of the study developed a positive screen for depression. In addition, 40% of those cases of depression went untreated. Even though there were mechanisms within the study to identify who was developing depression, and there was the option of referring for treatment, 40% continued to have these clinically significant levels of or scores on the geriatric depression rating scale, but they were not referred for additional treatment. What was interesting was that the depression score predicted increased difficulty with activities of daily living. And this was more significantly predicting these physical activities of daily living compared to motor symptoms of Parkinson's disease. Depressive symptoms also predicted an increased need for symptomatic Parkinson's therapy. So it was driving the clinician's initiation of motor treatment of Parkinson's disease was actually the geriatric depression scale, rather than more so than the motor symptoms themselves. Motor symptoms also predicted the need for symptomatic PD therapy, but depression was the greatest predictor. So it's telling us that these are very important symptoms early in the course of the disease. If they're treated, it may actually delay when an individual needs to start on Parkinson's motor therapy. Over time, these depressive symptoms continue to be followed. In a follow-up study by Dr. Ravina, they continued to look at the course of the depressive symptoms among individuals followed in this NetPD sample. In general, depressive symptoms remain mild, and about half of the patients with depressive symptoms spontaneously remitted or remitted for one reason or another within the following 6 months. However, the other half of the patients with these depressive symptoms actually developed more severe symptoms, and depressive symptom severity was associated with older age, a longer PD duration, as well as a failure to remit from the depressive disorder. So again, while many patients will remit with their depressive illness, others may actually go on to have more symptoms, and of course, as we showed before, that predicts having worse activities of daily living and more Parkinson's motor symptoms. To emphasize more the degree to which these symptoms are common, the depressive disorders are common and undertreated, we now are turning from looking at symptoms to actually the disorders themselves. And this is data from a study that I've been conducting in the Baltimore, Washington area over the last several years called the Mood PD study, or the Methods of Optimal Depression Detection in Parkinson's Disease study.